Okay. Good morning, the people on my side of the oceans, and good evening, the people back home. Welcome to today's conversation. As usual, we will start with our Hotuba person, our speech-led person, which is my brother, Karen, over there, my brother, Karen. And then we will go to we'll do the introductions because Wanjiro is new to the forum. So Kwala has been here before. Hamida, when you see her, Mumchune, but she's been here before. So take it away, Sire.
Welcome back and a happy new year to every one of you for joining. One mantra I've had before in life is one way to know a society's fears, hopes, and desires is to look at its idols. Because idols are the things that we turn to give us our sense of success and significance, and to use a bit of spiritual language, salvation. When I was preparing for this, almost every civilization that's existed has had different gods, but there's always a consistent thing. There's always a god of at least war, and there's a god of fertility. It seems the question of fertility is so big. Of course, we probably know names like Ankt and Aphrodisia, but it was interesting, a name like Brigid was goddess of fertility among the Celtics, so much for my friends who are called Brigid. But it tells you the importance that was placed on the question of fertility. In the story of the patriarch Isaac, when a wife had gone to be sought for him, when Rebecca was finally being released from home, among the many things she was prayed for was the idea of fertility, that she should be a mother of many nations. That was so important that it was not even prayed for secretly. It was one of the final words you'd hear from her people, from her home before she left. So intense is the question of fertility. The people have not just constructed religions or subsets of religions around it. So intense is it that people have constructed an entire identity ethos around it. It is people, like in Africa, once you get children, especially for the females, you lose your own identity. You stop being called whatever your previous maiden name was, and you acquire the name mother of or mama so-and-so. This becomes extremely paralyzing for individuals who, either because of pathology or other things like choice, are unable to get children, because within such societies, then the entire identity becomes a problem. Or to put it in more sophisticated language, it becomes a case where your pathology becomes your identity. People out here suffer from diabetes, but largely do individuals identify them with their disease? Or people would say heart condition or a stroke. We don't go around calling so-and-so stroke so-and-so, or so-and-so heart condition so-and-so. But in all societies, infertility was such a strong thing that it became an identity. We have strong words. I am Luya. The word for a woman who was barren was called Omkumba. It's both the wording and the implication behind it is so strong, but not just the disgust put on the word, but the whole summing of somebody's identity by the condition of their womb or of their uterus seems intense and unfair, but it is the reality of life. Many extreme things were done historically to try and either circumvent the issue of infertility or to try and cover it up. It led to cases of approved infidelity. In the case where a man was the infertile one, women were encouraged and even supported to go out of the home and be able to get children, and especially with people of consanguineal relationships. So it was quite often that uncles and cousins and nephews and even brothers sired children secretly on behalf of their otherwise infertile brothers. Intent is this, that to this day and time, we may have understood better about human gynecology and we may have understood the processes way better, but still the problem and the challenges of infertility are real. Marriages have been strained. Others have even been broken by this particular condition. And it is a sensitive topic because of the issues behind it, the pathology behind it, the identity that is wrapped into it. And I thought of a way of just wrapping this whole up. And I thought the challenge maybe just looking at the name, because when people have infertility, we either infer that they are not able to till their utility, or when people are infertile, we look at them in and we look at them far and we look at them as an untillable land. This has led to mental health concerns. This has led to family strain. This has led to things that we could not imagine. Money has been lost. Names have been destroyed. Unions have been compromised because of this. And we no longer can sweep it under the rug or just accuse the gods or demons to this. It's time we confronted this issue, talked about it, but moved away from just the curiosity, but walked to the courage of doing something different about it. It's time to have an authentic conversation about infertility. Back to you in studio.
Thank you, Saya. So we'll start with Geni siku ya kwanza, Dr. Ndegwa, and if you want to drop the doctor, you let me know. For there to be infertility, there must be fertility. Could you just let us know just the basic physiology of what it takes to make a baby? And if you can start from embryology, I won't hate you, just simplify the language. Thank you.
First, hi everyone. It's a pleasure to be here. I'm really excited because this is a conversation that is so dear to my heart. And I'm happy that the speaker before me did it so well. I mean, that was such a wonderful introduction of what really people struggle with and the heritage. She even gave the heritage and the importance of fertility in our society, especially the African society. But to answer your question, fertility is a couple's thing. I always say, of course, you have to have a man and you have to have a woman. You have to have the seed of the man, which is the sperm, and you have to have a viable egg or oocyte of the woman. And what happens is we have, as women, a menstrual cycle. So our menstrual cycles are actually a cycle in terms of monthly cycle in which our body tries to ensure that 1 or 2 eggs ovulate naturally. So women usually will, on day 1 or day 2 of your cycle, that's when everything starts getting up. And that's when your hormones are produced from your brain that allow eggs to start growing. And usually if you have a 28-day cycle, by day 14 of your cycle is when an egg is ovulating. If you have a shorter cycle, so it really depends on what your cycle length is, but it's different for everybody. And so once that ovulation is happening, what ovulation means is that your egg that is being produced in your ovary is ripe, to use a layman's term, and will actually rupture and come out of the capsule and will be taken up by the fallopian tube. So people think that the fallopian tube and the ovary are together, but that's not true. The actual thing is that the fallopian tube mops where the oocyte is being retrieved and actually comes and sits there and allows the small egg to go through the fallopian tube. And if you have copulation at that time or have intercourse with your spouse at that point, that's when the sperm is deposited, and there are millions of sperm. A normal male has more than 40 million sperm per each ejaculate. So those sperm are deposited in the birth canal. Now they flow up into the uterus and swim up into the fallopian tube. And actually fertilization occurs in the fallopian tube. And fertilization means that the oocyte, which is the egg, actually meets with a sperm, and there are millions of sperm that are around the egg trying to penetrate inside and actually cause a fertilization response. So the sperm that wins, of course, will enter through the hard shell of the oocyte, and then that's fertilization. Once fertilization has occurred, there's a cascade of processes that happens for the egg to start dividing. It actually starts dividing into smaller cells, from 2 cells, then it becomes 4 cells, 8 cells, until it forms something we call a blastocyst. Now, once it reaches there, it starts moving along the fallopian tube and moves down into the uterus and has to implant. So it has to attach itself into the uterine cavity. And once it's implanted, it means that we have achieved a pregnancy. And now what happens is that it starts to form hormones that will allow it to expand and also allow the attachment to continue. And that's the hormone that we check in the blood and in the urine when we pee on a stick to check if we're pregnant is actually beta-HCG, and that's formed from that reaction. And that just shows that something happened, implantation happened, and we are now pregnant. Now, for a pregnancy to continue, there's a lot of other things that happen, but basically that's what fertilization means. It doesn't mean that we'll have a baby at the end, because of course, you know, there are miscarriages, stillbirths, there's all these things that can happen. But for us, fertility really means that we have a live, healthy baby at the end of 40 weeks.
Okay. Dr. Sokola, do you want to add anything to that piece on fertility, because people ignore you and yet you're important in the whole fertilization journey? You as the endocrine, representing the endocrine society as a whole, not as God.
Yes, thank you. Thank you so much, Posa, for once again having me. And it's always a pleasure to be on this platform, where we are educating our people on aspects relating to reproductive health and other issues relating to the same area. And you know what, I'm very pleased that you always involve us as the endocrinologists in this kind of talks, like the one we had on the last talks that we had as well. And of course, I don't have words to describe the way Karen actually summarized the whole topic. And it's so true that in our society, infertility takes it's taken up very negatively and defines individuals. From an endocrine perspective, I think as far as the physiology is concerned, or the normal is concerned, I think Dr. Wanjiru has explained it excellently, and I don't think I could do anything better than that. Just to let you know that in the process that all this is taking place, all the way from the time that the ovulation is happening, all the way to the effect on the fertilized egg that comes out with when it meets the semen itself coming in, and all the way to implantation, and the whole entire process of pregnancy itself is all controlled by hormones at every stage, actually including the sexual function itself. So endocrinology is involved all the way from the beginning to the end. So if we are handling a case of infertility, then that is something that we have to keep at the back of our mind. And I think when we will be discussing the causes of infertility, then that's where we are going to involve to discuss more about the endocrine aspect. So the brain is involved in controlling the hormonal performance in infertility, in the whole process of any pregnancy or reproduction. And the brain has got 2 main organs. One, they've got hard names, you may not need to know all of them, but there's one organ known as the hypothalamus, which controls another organ in the brain known as the pituitary gland. And these are not very big organs, but they are extremely important because they regulate the hormones that are produced in the body. And they have these negative feedback loops, and which usually we would be discussing when you're looking at the endocrine causes of infertility. Other than the brain, the thyroid gland is also involved in maintaining a normal reproductive cycle. Same with what is known as the adrenal glands, which are small glands on top of the kidneys. So all these work in collaboration to be able to achieve a successful pregnancy or achieve fertility, in other words. So yeah, I think that's what I would add up from as far as the normal is concerned.
Okay, Hamida, for the sake of you not appearing as chopped liver here, do you have for the fertility part, do you play a role in it, or as the because you're representing the psychologists here, what's your role in the fertility before we go to now the abnormal, which is infertility?
Thank you, Pastor. I think, of course, infertility comes with a lot of distress. You can imagine when you want something and you want it so desperately and it's not coming your way, it will definitely have an impact on you as a person, whether it
sorry, Hamida, the fertility part. We will start infertility the next round.
Oh, sorry, can you repeat the question?
No, because we have to define the normal. So we start with fertility. What's the normal? So I'm just asking so that you don't appear as chopped liver. In the fertility part, the baby making part, what's your role as a psychologist? Not the non-baby making part, if English.
Of course, we. Sorry.
Yeah, go ahead.
I'm just saying, when we look at fertility, we look at it as part of the stages from coming from childhood to becoming an adult, and parenthood is part of that transition. So it is one of the things that is expected of us, whether we get to achieve it or not. So it is part of what the society expects of us as human beings to be able to bring forth the next generation. I hope I've been able to answer your question.
Yeah, I was just, I'm always unfair to you guys. So just thank you for always and entertaining me. Okay, Wanjiro, you're up. So let's define infertility, and then what's infertility now?
Okay, so infertility is the inability for a couple who have been living together for at least 1 year and having regular intercourse, which is 3 to 4 times a week, to not conceive. So basically, you live together for a year, you're in a relationship, you have intercourse 3 to 4 times a week, and we've not conceived in a year, then that's a big sign that we have an issue in terms of our fertility. I don't like to say infertility because it's such I don't know, I find it so too much. I say subfertility because most cases can be rectified and help can be done, but infertility means, well, we can't do anything about it. So I would say subfertility.
And we have to emphasize is penile vaginal sex because there are other forms of intercourse.
Yes. And sorry, I forgot that usually this is also dependent on age. So if you are 35 and over, we give you a duration of 6 months. If you're 35 and younger, we give you a duration of 1 year. And that's just medically, because if you're 35 and older, we want to see you as fertility specialist a little bit earlier, because there may be, your time is not as long as a 25-year-old.
Why the distinction? Is it that we lose eggs with time, or why the 35 age cutoff?
Yeah, so as women, yes, we are born with a certain number of eggs, and we lose them every month during our menstrual cycle. So we don't lose 1 egg. We lose a lot of eggs, maybe 20, 30 per each menstrual cycle. So by the time we reach 35, we've lost a lot of our eggs, and we don't have time, because usually past 43, it's really difficult to conceive. So because you have like 8 years or 7 years to really conceive, we want to see you a little bit earlier.
Okay. So then let's just go into the thick of things. So what are the causes of infertility and because we'll start with you again, Wanjiro, because this is your bread and butter. What are the causes of infertility?
Okay, so the causes are twofold. Of course, there's a male factor and there's a woman factor, and then there's the where both partners have a problem. So I just want to say that usually it's really down to the middle. So usually 30% of women will have a problem, 30% of males will have a problem, and another 30%, both the male and the female in a relationship will have a problem, and 10% of couples will have unexplained, where we don't see any reason for them not to be conceiving. So for a female, I wish I had my reproductive organ, but really I'll start with that. For females, it's really the reproductive organ. So the most likely cause, or the most common cause for us, is blocked tubes. And if you remember that I said fertilization occurs in the tube. So if the sperm cannot reach, if the egg cannot meet the sperm in the tube and they're blocked, then we will not conceive. So that's number one. So that's structural issues in the reproductive organ. And the tubes can be blocked for so many reasons. They can be blocked because of STIs, STDs, which is a common cause, but they can also be blocked right now. We are seeing more cases of patients who have endometriosis, having blocked fallopian tubes, TB, silent TB that you never even knew you had. We are finding that sometimes you go in for a laparoscopy and you find TB all over the pelvis. So that's another reason. But that's an infection. So usually it's infection and some conditions like endometriosis. Another reason why you may not be conceiving is something structural inside the uterine cavity. So remember we talked about implantation, where the embryo that has been formed has to come and implant into the cavity of the uterus. So what happens if there's a big fibroid in the cavity? It will not be able to implant. What if there are polyps? Polyps are little things like they really look like what's in the sea, polyps. Those can also obstruct implantation. There are silent factors that can affect implantation, like your immunity, some immune cells attacking the process of implantation. So, but structurally, usually it's a fibroid sitting there, or it is a polyp, or sometimes it is adenomyosis. Adenomyosis is another disease where the cells have gone into the tissue of the uterus, and then it also affects implantation. And endometriosis also affects implantation in ways that we still don't understand. Other factors that could be causing infertility in a female would also be age. So age is now, well, should have been at the top, to be honest. We're seeing more and more of us waiting, wanting to have career, wanting to have our PhDs, wanting to be established in life before we sit down to have a child or before we have a partner. And this is really taking a toll, because we're seeing older patients, maybe you're 40, 42, 43. And if you remember, I said that your egg count is extremely important and it reduces with age. And there's a huge drop from the age of 35. So we will have a problem with not only the numbers of the eggs, but also the quality of the eggs once we have past the age of 35. So age should have been actually number one. Then there are also endocrine factors, which I'll leave to the endocrinologist. But just to say one that is really important, there is something called polycystic ovarian syndrome. And that's one of the diseases that affects ovulation. So we have to ovulate. Of course, the egg has to rupture for it to get into the tube and meet the sperm. So if our body is not ovulating, and polycystic ovarian syndrome, which is PCOS, is one of the diseases that a woman may not ovulate for years or months, but even 9 months, a year, she's not had any single menstrual cycle. So, or has not ovulated, even if she's had withdrawal bleeding. So some of those factors, if you don't ovulate, then you will not conceive. So that's another common one. For male, I'll just go to male. Male factor is it's actually increasing, I think, in our country. I'm seeing more and more males factors, and it's varied. So we can have males who have no sperm, or who have low sperm count, or who the sperm are not moving too fast, or who the sperm are abnormal. And a lot of factors right now are lifestyle. So we're having more patients who are doing smoking, nicotine patches. There's a lot of bangi and mira and alcohol use. So that's one of the factors. And also sedentary lifestyle. All this affects your sperm and the foods that we eat, your sperm counts and your sperm motility and the way they look. So that's one. But also there are patients who have inherited either genetic issues that they were never born with sperm, some who got STIs and STDs and it actually blocked the tubes of the male that take the sperm out into the ejaculate. Yeah, so there are many factors in terms of the sperm factors as well, and then endocrine factors as well that I guess the endocrinologist will explain a little bit better. I'll leave that for her.
Okay, so Kwala, your app, give us the what are the endocrine causes of infertility?
Yes, so endocrine causes, you should start suspecting an endocrine cause. Like, let's say a patient coming to you and they've not been able to conceive, like Dr. Wanjiru has already explained brilliantly. So when should you consider that probably there's an endocrine cause, or when should Dr. Wanjiru or the gynecology or obstetrician now start thinking, that there could be something endocrine going on? So one of the most common symptoms that they would present with, which would make you suggest that there's something endocrine going on, is ovulatory problems. So like menstrual issues. So when your patients come and tell you that my menses are irregular, already you should start thinking about possible endocrine issues. So as you've ruled out the structural issues like the way she described, or simultaneously when they've got ovulatory issues or menstrual issues, there should be a simultaneous evaluation for endocrine problems as well. So what are these endocrine problems which we are looking at? So Dr. Wanjiru has already mentioned polycystic ovary syndrome, which I think we needs a bit more discussion, and probably at some point a whole session on it, because there's a lot to discuss with PCOS related to the endocrine aspect, the fertility aspect, the nutrition aspect, the cardiac aspect. Is quite a lot. So I'll not go too much into the details of that, but let's start from the top. So we said that fertility is controlled from the brain, right? So if you've got a problem in the hypothalamus, the main center that controls now the rest of your hormones, for example, if someone has had a trauma to the brain, a brain injury or trauma, and they've got damage to that hypothalamus, or there is probably some infection that destroyed that area of the hypothalamus, like tuberculosis can affect the hypothalamus and the pituitary gland as well. Or conditions like tumors, which is like the more common thing is if you have a tumor sitting in the brain in an area suppressing the hypothalamus, then that could affect. And these are all pathological or disease causes of having infertility due to endocrine reasons. But one thing I must tell you is that there is something known as physiological causes of hypothalamic problems, which is conditions related to physiologic and functional, which is like excessive exercising, excessive vigorous physical activity can actually lead you to get suppression of the hormones that are being produced from the brain or from the hypothalamus, which are the gonadotropin releasing hormone, which releases other hormones now from the pituitary gland. Maybe you have heard of things known as FSH and LH. You probably don't need to know the details of those names. But sometimes when you are, we recommend good physical activity or good lifestyle modification. But when you go overboard with physical activity, then it can actually be suppressive to the brain. At the same time, when we look at causes like there are some dietary issues also which could suppress high energy diets, high caloric diets. In male, especially intake of androgens, like steroids, maybe for muscle building, those could affect their hypothalamic hormone production. So issues related to the hypothalamus, and then coming to the pituitary gland. So the pituitary gland produces the main female and male sex hormones, which is known as the FSH and the LH. And whenever there's a problem with the production of these hormones, either because of congenital problems, which affect the hypothalamus and pituitary, where patients could be presenting for the first time with infertility, and when you take a history, then they have got issues related to problems with their smell, for example, and yet also they are not able to produce these hormones from the brain, and that is usually related to birth-related issues with reduced production of these particular hormones, which control the rest of the hormones. Another thing that you could have is, again, tumors in the pituitary gland. And this could compress or press on the pituitary gland and reduce your production of the hormones, the reproductive hormones, or also reduce or increase rather the production of another hormone known as prolactin. Now, prolactin is the hormone that physiologically or normally is produced in the brain to control your production of milk, especially in women. There is the production of this hormone known as the prolactin, which is important to regulate the milk production for the baby. However, when this hormone is produced in excess, it actually has a suppressive role on the production of the other hormones, and it can actually lead to subfertility or infertility. So that always has to be assessed whenever you are looking at assessing the hormonal aspects of infertility. And the signs that the patient would present with, if it's a female, there would be irregular menstrual periods. There could be nipple discharge in a woman who's not pregnant. And in males, they could have excessive breast growth, which is known as gynecomastia. They could have sexual problems as well. The energy levels could be affected because there is regulation of the male sex hormone also with this hormone which is suppressed. So those are the things that would suspect towards that. So moving from the pituitary gland, then you've got effects on the thyroid. We come to the neck. So there's the thyroid gland here. So a high thyroid production, an overthyroid production, or a low thyroid production, both can affect your fertility because they do affect the reproductive hormones. And then if you move down, then you look at your adrenal glands, which are the glands situated on the top of your ovaries, of your kidneys, sorry. They're small glands which produce a lot of hormones like the steroid hormones, which usually they control our stress, but also there's a section in the adrenal gland which produces the sex hormones, which also control your ovarian or your testicular production of the sex hormones. And sometimes when you have a problem in the adrenal gland, which could be even related to extra production of your cortisol levels or lower production of your cortisol levels or excessive production of another hormone, which is the sex hormone known as DHEAS, which could be produced in excess in the adrenal glands. All these could affect fertility in one way or another. And then you come to the ovarian or to the endocrine aspect of the ovary itself or the testis itself, which themselves are also endocrine organs, means that they do produce hormones. So when you have got a disease in the ovary itself, like we were discussing about polycystic ovary syndrome, you could have an issue with production of these hormones. Again, there's another interesting component, which is very similar to polycystic ovaries. It's known as congenital adrenal hypoplasia. So that is in the adrenal gland that I was talking about. You could have a congenital problem or a birth-related problem which manifests later with features very similar to polycystic ovary syndrome, where you have got excessive production of the male sex hormone in the females, and they get the same, excessive hair growth, excessive acne, period, like menstrual irregularities, and weight gain. And that's why when you're being evaluated, even for polycystic ovary syndrome, or for subfertility or infertility related to this kind of a situation, then we do some tests to also rule out this congenital adrenal hypoplasia. So I think in a nutshell, I've covered all those things. It starts all the way from every endocrine organ. When you have an imbalance, then basically you can in one way or another have a higher chance of subfertility. And when I talk about that, one important component is diabetes. Diabetes itself can lead to, through multiple mechanisms, it can actually lead to reduced fertility levels. Secondly is obesity. When you talk of lifestyle factors, I was very happy that you mentioned the other aspects of smoking, alcohol, and the rest, but also obesity on its own. I'm currently actually doing a whole review on the aspect of obesity and fertility or infertility, and it's just shocking the level of link that are there connecting these two conditions, and we take it for granted. But obesity actually worsens your potential for fertility, and just about a 15% weight loss can actually even normalize your menstrual cycles and dramatically improve your chances of fertility. So yeah, I think I've mentioned most of the endocrine causes.
Okay, as we can see, there's no one answer to cover. Like if you're told you're infertile, there's a whole slew of things you have to think about. Okay, Hamida, you're just gonna chill for a while because this is other organs before we get to you. But let's go back to Wanjiru. So how do you approach an infertile couple? Because a person is not infertile on their own, but it's as a couple.
Okay. So I think it's one, I want to applaud people or couples who are coming because now we're seeing more couples, or I mean, a man and a woman coming. I remember when I started my clinic, it would be the woman alone, and interestingly also the man alone, who wanted to check his sperm count before either marriage or something like that. So I do feel that the first step for anybody who has tried to conceive for either 6 months or 1 year, depending on your age, as a couple should come together into the clinic as a couple. Because we take a history, the first thing we do is ask a bunch of questions, and these questions try and to help us pinpoint where the problem could be. As much as we can do that, we also have to do several tests on both the male and the female to actually understand where is the problem. And as much as we do that, sometimes we find that there's really no problem, and maybe we just have to try things and see, depending on the length of time you've been together. So the first thing we would do for the woman is I like to tell couples to start their journey on day 2 or 3 of menses, because that's the day that we can actually do a scan. So usually I do a scan that checks the number of follicles, which is the number of eggs in your ovaries. It's a very, very important scan because it tells us the likelihood of your success, unfortunately. I know quantity is not equal to quality, but there is a link in terms of that. And because also it's highly linked that you will have a higher number of eggs the younger you are. So that is called a transvaginal scan that is done on day 2 or 3 of your menstrual cycle. Now, as well as looking at your ovaries, we are also able to look at your uterus and see. And it's a very important stage because the uterine lining is supposed to be at its thinnest. So we sometimes are able to check and see that there are polyps there or that there are fibroids. Sometimes we can see endometriosis, and sometimes we can see adenomyosis. All of these do affect your fertility. So that scan is really, really precious, but it is also observer dependent. So it's very important to go to somebody who actually knows what they're doing and is well trained on those scans. So that's number 1 for a woman. We would also like to do a couple of tests, hormone tests on that day, depending on different factors. So it's not, the number of investigations or the tests are not the same for everybody. So if we suspect from the history that you have issues with maybe ovulation or other factors, we may do follicle stimulating hormone, LH hormone, or a bunch of hormones, just to see what they look like on day 2 or 3 of the cycle, because they do go up and down. We also do thyroid tests because your thyroid is part, as Dr. Sokwala, thyroid, prolactin. If you have PCOS, then we do your FSH, LH. So those things would be done on usually day 2 as well, just to see what they look like. There's also a very important blood test called anti-Mullerian hormone. Before, we used to think that this was the wonder. We'd look at it and tell somebody you can't conceive. And I did that when I was younger. And I'd look at it and say, I'm sorry, this is just too low. And then 6 months later, someone will come and have conceived, and you look very stupid. But it was because it was the wonder hormone that would tell us the success rate of somebody conceiving. Now we know that it is not equal to success. We just know that it gives us a little bit of inference, but it is more for the doctor to, especially if you're undergoing an IVF cycle, to determine maybe the dosage of the medication that you would need, but it does not equal to success or no success of to conceive or to have a child. So after we do that, we would need to see you again, probably on your 9th, 10th, or 11th day of your cycle. And that we would be doing a test called a HSG. So a lot of people know what this is, especially people who have been looking or are trying to conceive. This is a test to check if your tubes are open. A lot of people are very fearful because it is a painful test, but unfortunately, it is extremely necessary to be able to assess the tubes. Because if your tubes are not open, we are not going to conceive. So instead, it's a test that I usually insist on doing because we need to know. We really need to know. There are other forms or other ways to check tubal patency. We could do something called a Hikosi, which is we put not the painful test, but it's still painful. We could do a scan and put a gel that goes into the tubes to check, but it is not as sensitive as the HSG. We could also, because I have patients who tell me it's too painful, can you put me to sleep? Can I have anesthesia? And then when I tell them the cost of the laparoscopy, because we can also check via laparoscopy, which is we put a tube with a camera into your belly button and we push dye when you're asleep through the birth canal that goes through the uterus and will show the fallopian tubes actually spilling the dye. That can be done, but it's very pricey for a test that costs probably in Kenya probably 5,000 to 6,000 shillings versus 100 or 200,000. So those are other ways to check for the tubes. And that's basically the workup for the woman for the first bit. So that's the preliminaries that most people will have to undergo. And then for the male, we'll do a semen analysis. So for a male, we'll just need him to have abstained from 3 to 5 days of abstinence. And he'll have to, unfortunately, masturbate a sample, usually at the clinic, because we need the sample within a certain time to give the right parameters. And that sample is usually taken under a microscope, prepared a little bit, and we look at it. And for the males, we're looking at how many sperm we have, because we need a count of above 40 million. We are looking at how fast they're swimming. At least 32% of your sperm should be swimming very well for us to say, okay, you could conceive. And we also have to look at the way they look. Do they have a head? Do they have a middle piece? Do they have a tail? And do they look normal? So if they are 4%, actually the threshold for normality is very low. A man who has 4% of his sperm as normal will naturally conceive. So usually men have a lot of sperm because a lot of them are abnormal or not swimming as fast. And that's normal actually. So that's the male part. So if we do those investigations and everything is okay, or we don't find too much, we may then go into the immunology for the female. So we may want to look at the uterus itself and just see and take some biopsies. Is there a problem at that level of implantation? Are we unable to sorry, my computer is almost going off, so I need to plug it in. But yeah, so implantation. So we'll be checking for biopsies and checking what can we see. Posa, you'll allow me to put my computer back on before it goes off?
Yeah, no problem. I can entertain the people.
Yes, sorry.
If you have any questions, you can actually unmute, raise your hand and unmute and ask if there's anything we need to clarify. I know we keep saying throw in medical jargon. Congenital just means born with. I don't know what else you might have missed, but just yeah, in case anything ilikupita, just let me know. No questions so far. Do you need to see a picture? You're too silent. If you need to see a picture of a uterus with all those things, let me know so that I can hunt for it on the webs and send it to you. I don't want to go to Dr. Sokwala because I want Dr. Wanjiru to finish her train of thought. But maybe I should ask Hamida. Hamida, are you, oh, there's a whole lot, this one, did you type, Vincent, did you type it on Word before you pasted it here? Okay. How often, Okay, we'll wait for this. These are 10 questions, so we'll wait for her to come back. Hamida, at any point, okay, sorry, let's just go back to 10, then I will ask my question when she's done. Okay, 10, go ahead.
Yeah, sorry about that. I was at the male aspect, and
Yeah.
I think I'm just really telling you about the sperm. And no, actually, sorry, I was at the female aspect, where if we have found that everything is okay, but she's still not conceiving, then we'd go to the immunochemistry or immunology of how implantation works, and we'd maybe probably do something we call a hysteroscopy and a laparoscopy, just to see is there very silent endometriosis that we can't see, but we'll see surgically on the uterus. Are there polyps, or are there signs of chronic infection in the uterus that we couldn't tell just with a scan? So those are other things that could be done. And sometimes, unfortunately, it's done after you've done an IVF cycle, and we have beautiful blastocysts, but we're wondering, why aren't you getting pregnant? But that sometimes explains, and we're able then to find out the reason and help you get pregnant.
Okay, as you digest the question, Vincent, the questions Vincent has put down, let's go to Sokwala. So what's your approach as an endocrinologist to infertility? When do you pair up with when do you partner up with 10?
Yes, so, you know, so many times patients nowadays, with the level of education growing, also understand that endocrine is equally as important as part of fertility. So sometimes we get patients coming in with the conditions primarily related probably with other symptoms. Let's say if the patient has got thyroid issues, or which are presenting themselves, whether it's high or low thyroid. I think Vincent asked about the thyroid, whether it is present in both males and females. So yes, definitely the thyroid is a gland which is present in the front of your neck, which looks like it's actually a butterfly-shaped gland, which is present in the front of your neck, and it's present in everybody, males and females, unless it has been removed for any reason, right? So it actually makes your internal body's functioning to be kind of in a balanced state, where it controls your heart rate, your pulse, and your metabolic rate. But basically, if it goes haywire, whether there's excessive production or low production of this thyroid hormone that is produced by the thyroid gland, then that can affect fertility as well, related both to male and females. Now, going back to the question is the evaluation for fertility. So if a patient comes in, either as a referral from the gynae clinic, usually most of the times we see that our gynecologists would have done at least some baseline assessment, and especially if the patient has ovulatory issues, or they've done a screening test and they find that their thyroid levels are not normal, or they find that you know, they've done a prolactin level and it is very high, then those are the cases that are usually referred to us. But generally, anyone presenting with menstrual irregularities should start being considered for endocrine evaluation. And if they've got obvious symptoms of endocrine diseases, like, for example, if a patient comes in with infertility and you get a history, because you see many a times the point of contact would probably be the gynecologist, right? So when they come to the gynecologist with issues like headaches, vision problems, and also they've got issues related to their periods becoming irregular, or they're having, you know, like nipple discharges in females, or excessive breast growth in males, then when the patient first of all comes, the gynecologist, the first point of contact should take a very detailed history related to all these symptoms. And that should create suspicion that there could be something going on in the brain, probably related to the hypothalamus or the pituitary gland. So that is the kind of patients that would be referred to us, and that's when we start our evaluations with like hormonal tests, and also probably imaging of the brain. We might end up doing an MRI of the brain to look at the pituitary gland or the hypothalamus that we discussed. Then thyroid problems. So what would the patients come with? So if it's related to hyperthyroid or excessive production of thyroid, Then, like I said, the thyroid controls, puts you in a balanced metabolic rate. So everything will be going fast. So the patient will be having symptoms of like palpitations. You're feeling your heart rate. You're feeling excessively hot. You're losing weight. You are feeling excessively hungry. So those are features related to hyperthyroid, which would suspect you to check for high thyroid levels. And we have cases, literally, we've had cases referred from the gynecologist where they've been followed up in multiple places and no one really checked for the thyroid. And one gynecologist decides, oh yeah, let's just check the thyroid gland. And they find out that the thyroid was overfunction or like hyperfunctional. And this is a patient who has been with that for the last 1 year, and probably no one has thought of assessing the thyroid gland. When it's low, then the same thing, you've got everything going low, like you get tired very easily, you gain weight, patients are constipated. Those are some of the features which would now suggest you to also evaluate your thyroid. And when we do the thyroid function test, there's something else also that is very important, and that is known as the antibodies. Like Dr. Wanjiru mentioned about immunity or immunology, as far as the immunological tests are concerned otherwise, but also with the thyroid, we need to check their immune status. So there are tests which check your immune status. So if you have got subnormal or lower, not very significant thyroid hormone levels being significantly low or high, but you've got this immunity or antibodies being positive, then you are at a higher risk of subfertility or infertility due to that thyroid problem. Again, when sometimes patients come, they come with issues related to excessive hair growth or acne in the first case. And sometimes they even refer to us from dermatology, where they've gone just for evaluation of this excessive hair growth or baldness, on the head for this is for females, and excessive, Sorry?
No, I need to mute someone.
Yes. And when they come, they go to a good dermatologist, the index of suspicion should be there, where they realize that, oh, something is wrong, and then a good dermatologist will probably ask them, do you have problems with your menses? Are you seeking fertility care? And in that case, then you pick cases of like polycystic ovary syndrome or congenital adrenal hyperplasia that I was talking about, or it may be the first time you've picked a tumor of the adrenal glands. So these kind of symptoms should be what could give you a higher suspicion. And actually, in addition to what Dr. Wanjiru said about evaluation for infertility, yes, we talk about those who are less than 35, 1 year, more than 35, 6 months. But anyone who has any of these kind of symptoms should actually be started to be evaluated even earlier than that duration. So like, let's say 3 months, someone is not conceived, but they have got features of thyroid disorders, or they've got features of polycystic ovary, then those are the patients you need to start evaluating much faster and try to control the underlying condition, because sometimes when you control that, you can actually achieve conception without having to go through your complex procedures or artificial reproductive technologies and all those, or assisted reproductive techniques and stuff like that. So it's important to evaluate for endocrine causes of infertility in both males and in females, right?
Okay, thank you. We're getting some questions from the Facebook side. Let me just summarize them. If you could, Wanjiru, I think this is for you. If you could summarize what the impact of TB on infertility, and then any of you can touch on, Sheehan syndrome. You will Sheehan syndrome and eating disorders and excessive exercising and the effect on fertility. Wanjiru, go ahead. Yeah.
Yeah, so I will touch on the TB part. I mean, I think TB is one of these very silent illnesses, and a lot of so sometimes, or what we've been seeing is that you may not be conceiving, and once we go in for a laparoscopy or a hysteroscopy, when we do the biopsies, we find signs on histopathology. When it's taken to the lab and assessed, or even by our eyes, sometimes you can already see that there has been TB that has been very silent, was never treated, it's dormant in either your uterine cavity, because that's becoming more common, or it was there in your pelvis and it's actually blocked your tubes or affected your ovaries. So we've seen that, and the problem is that TB in our setup in Africa is a dormant disease, and may affect without actually giving you a lot of signs until you have something that's causing you to be immunosuppressed. So immunosuppression means if you got an illness that caused your immunity to go down, then it flares up. So that's what we are seeing for some patients. It's not for everybody, but sometimes we're shocked. And when we take the history back, someone will say, yes, I remember I had a roommate in campus who had TB, coughed a lot and then was discovered to have TB, but I didn't get it. Or I had, my mom had TB and so it's things like, or I took care of somebody with TB and I never got it. But so it's really sad. It's something that we really can't do. It also affects the males in the same way it may affect, we've had men who had orchitis. Orchitis is a swollen testicle. Were put on antibiotics, and what happens with antibiotics, the TB will respond a little bit, it will go down, and maybe nothing else happens and you just leave it at that. And then when you come, we don't have sperm, or we have low counts, or so TB is one of the illnesses that I am pained by, because you don't do anything to get it, and it's just really bad luck.
And it's one of the reasons masking should be encouraged. If I know people are not pro-masking, but one of the reasons you should mask is the TB you could get the first sign could be even multi-drug resistance. Dr. Sokwala, the exercise, the eating disorders, and the Sheehan syndrome.
Yes. So I mentioned briefly that there's something known as functional hypogonadism, which is a condition whereby you've got your hypothalamic hormones are suppressed, because of these issues related to diet and exercise. So we recommend moderate physical activity. So what we do recommend for anyone to stay healthy, even if you're not obese or overweight, what is recommended, even as per all the guidelines, is at least 30 minutes of physical activity, a list of moderate intensity physical activity at least 5 times in a week. So we say at least 150 minutes in a week. But there are some people who are aggressive with that. So they would go probably even 2 hours in the gym every day of the week, excessive exertion and excessive physical activity. And even sometimes in athletes, this has been seen, where there's excessive physical activity that could suppress actually the brain rather than improve your functioning of the hypothalamus, and could lead to not the brain, but the hypothalamic part where the female and the male sex hormones are being produced, and that could contribute to subfertility or infertility. And so that's something that should be addressed in this kind of people who are sports involved in sports and or vigorous physical activity. And same thing applies also to the other component of diet, whereby you have got issues like bulimia, like there's excessive the self-induced weight loss techniques where you've got anorexia nervosa or you've got bulimia. Now, these conditions also could predispose you to get hypothalamic problems, and these are then known as functional hypothalamic disorders. Another thing that we mentioned is Sheehan syndrome. This is like after delivery, when you've got a problem with especially when women lose a lot of blood after delivery, then that could suddenly reduce the blood flow. That's a postulated mechanism, or thought to be this is the reason. There's reduced blood flow going to the brain, and that could lead to a problem with the pituitary gland developing reduced production of the pituitary hormones. And that in the future can predispose you to develop infertility. So that's something to also consider, especially in women who have conceived already. Then suddenly they're presenting with, after a while, after their postpartum period is over, then they're still presenting with reduced periods of amenorrhea, and the babies are not breastfeeding, but they're still, leaking, let's say they're still having nipple discharge. So those are the women that you have to consider for possibility of Sheehan syndrome. And Then you need to evaluate the brain, you have to evaluate the pituitary gland and see if that is what is going on. So the pituitary gland, like I said, does not only produce hormones related to the reproductive system, but also overall it produces hormones that control your thyroid function, that control your stress hormones, that control your body's growth, that is the growth hormone. And derangements in any of those axes, even if there's a problem with the growth hormone axis, or there's a problem with the cortisol, or rather the stress hormone levels, where there's excessive production of these stress hormones, that itself can also affect your reproductive organs in different ways. Or when there's suppression of these hormones, now when you've got reduced blood flow, for example, to the pituitary, in this kind of a situation, then you would have reduced hormone levels all over. And then you need to consider supplementing these hormones to be able to achieve probably a healthy pregnancy. I hope I've answered the questions asked.
Yes, you have. And so, because you've touched about, the Shehans, let's talk about secondary infertility, as in you got 1-2 babies in succession very well, but you're struggling to get the second or the third one. And that could be due to secondary infertility. Wanjiru, can you take a stab at that?
Yes, I just want to say that fertility is not static. I mean, just because you got one baby doesn't mean it will be easy to have another one. And the reasons are various. One of the most common is that your tubes could, you could get an infection, you could have endometriosis, something could happen to your tubes. You could even get an ectopic pregnancy, maybe twice, which we've seen patients who've got an ectopic pregnancy and then later they get another ectopic pregnancy and we have to remove both their tubes. And therefore, at that point, then that is secondary infertility. But there are also cases where, apart from that, you have had your baby when you're 27, and then when you come later, you're 40, 42, 43, and you're struggling also because of egg quality. For the hormone issues, as Dr. Sokwala is really explaining well, your thyroid issues could happen at any point. Hyperprolactinemia could happen. There's diabetes. There's the lifestyle things that also people do that could also reduce their counts. So that also changes with time as well. And even for a male, I think it's important. I know I've had consultations where a man says, no, I have an 8-year-old. And to be honest, the 8-year-old looks exactly like him. But when we come in there, the sperm are very few sperm. Morphology, the way they look is very, very poor. So that can also change. Your sperm count can change because of either infections or because of lifestyle or something, or even, and lifestyle can be also occupation. So that's something that people need to know, that you are more likely also to have lower sperm counts if you are on hot areas, and sometimes also because chemicals. So if you work in the paint industry or industries where there's a lot of inhalation of toxic chemicals, that can also affect. So we've seen that. So that you could have fathered a child before, and then later the sperm count is not able to father a child naturally.
Okay. Dr. Sokwala, if you have anything to add on the secondary infertility, I want to move to Hamida before she thinks we just brought her here to watch.
Yes. So just I think the aspects related to lifestyle should also be considered heavily, right? If you suddenly gain weight, or you've got like you've just let go and you're gaining weight, you see other factors related to lifestyle. You started smoking, you've started binge drinking, you develop cholesterol problems, you've got other issues. So those things also, or you have started taking some drugs, for example, some medications also could affect fertility. Or, it's not only a product of basically just not being able to get children, also the trial to get children also can be affected, like stress levels. When your stress levels are also very high, that itself could affect your aspect of fertility. So secondary infertility is real, and there could be reversible causes, or there could be even irreversible causes related to it. When you look at male factor, I think one thing we have not really touched on is the irreversible aspect of infertility, or probably the very difficult to achieve reversibility, is things like what we call as primary testicular failure. So, for example, you could have a male patient who does his semen analysis, and there's literally no sperm that is found. There's no viable motile sperm, and that happens. And that is known as primary testicular failure, where it's unfortunate that in that case, you cannot really, it's very difficult to achieve pregnancy. But even in those cases, we do something known as testicular sperm aspiration, where there's biopsies taken of the testes to assess whether there's any viable sperm that is available to try and achieve now assisted reproduction, like using techniques like IVF, or something known as ICSI, which is a form of assisted reproductive technologies. But basically, that's one form of very difficult to treat infertility, especially if it comes later. And yeah, I think Dr. Wanjiru covered most of the other aspects, and I think we should let Hamida take the floor as well. Thank you.
Okay, Hamida, you're up. Okay, because we now need to offer hope for those who are fighting with infertility. Hamida, do these couples come to you? Do people come to you, and what do they say, and what do you do?
Thank you, Posa. Yes, of course they do. As you can just listen to the doctors, I mean, they have done a fantastic job just explaining to us how complex the whole journey is. So that also brings up a lot of stress. And unfortunately, it can also lead to other psychological complications, like, having depression, because you're trying and there's nothing coming forth. The pain of having your periods, thinking that this month I'm very hopeful. I'm having all these signs. I feel like I have conceived, and even maybe your periods delay a bit, and you are starting to have a little bit of hope, and then suddenly your periods are there, and you have to talk to your partner about it, that the periods are, you've received your periods. It's quite a heartbreaking, process. So it may lead to depression. It can also lead to anxiety issues, because you are constantly on edge, constantly waiting. You are having so many tests being done, so many procedures being done. And also some of the procedures are quite invasive. It's like sometimes they talk about, your private parts, especially as a woman, not being so private because of the procedures that you have to go through. So it is an intense process, and it can also, like I've said, come with a lot of anxiety, a lot of, things that you're not sure of. It's like, is there light at the end of the tunnel? We also have issues related to, the relationship, the impact that, the process of getting treatment can bring to a couple. There might be some misunderstanding, and also sometimes blaming. Sometimes even in our culture, as Kenyans, the extended family might start getting involved and coming up with their own, suggestions, their own ideas. For example, get another wife, and there's this stereotype that the woman is always the problem when it comes to, issues of fertility. Yeah. And a lot of, stereotypes. So there's a lot of mental health anguish, mental health distress that comes along with this journey of, first of all, the subfertility, trying for a baby. It's a very stressful process. And also, using other alternatives like IVF. It's not a guarantee. It's quite expensive. So there's also the financial aspect of it that brings stress. There's also, the issue of maybe not being able to succeed when you've gone through an IVF treatment. Then you have to go back to the table and look for other solutions. So it can be very, very complicated, and people talking about exploring other options like adoption and what that looks like. So it's a whole a very wide and complicated situation at times. Yeah.
Okay. Wanjiro, let's start with you. So what's next? What is in the market? What is out there for people? I know that there are different courses, but what is out there that you can do for these couples fighting infertility?
Yeah, well, I think there's a lot that can be done, but I would want to just stress what she said, that really it is a journey and it is difficult, and there is a lot of mental anguish, and it's expected, because I mean, just as at the beginning, the introduction, a baby is so important. It's so important to have heritage, to, you know, to feel like you left a mark, or that mark on the world. So it's really, the psychological aspect is really, really big. But that being said, there is a lot that can be done. But patients need to understand, and I will stress this for the females, that we are not spring chicken forever. Even if you look so good at 60, you cannot bear a child at 60. So we do have, unfortunately, an expiry date for conception or for egg fertility of your own genetic offspring. And we do need to realize that we can chase the PhDs, we can live in the big houses, but it's lonely if you are there alone. So we do need to decide what is important for us as women. And sometimes hindsight is the only thing we have, but it's really important to decide, do I want children? Because not everybody wants children, and that's okay. But there are a number of people who come at 40, at 46, when it's too late, and are like, you know, I always thought I didn't want children. I have been in relationships with different people, but never really wanted to settle down. But now I'm empty. And that really happened during COVID. It really, really happened during COVID. Sorry, I'm going in a long story, but I want to say this because it's something that I want women to understand, that we have options, but we have options for our own genetic offspring until about really 42. After 43, it gets difficult. I'm not saying you can't conceive at 43 and 44, but the likelihood is very low, even with IVF, even with at the best center ever. And that's why in Europe, if the places where they actually give cycles for free, and I trained in Belgium where they gave 6 cycles, but after 43, they do not accept you in the program, because they know that they're just, the success rate is actually not commensurate to what the government will spend on those IVF cycles. So if that is happening in Europe, I mean, we need to really make decisions. Now, there are very many things. I will talk about the easy and simple things, like for patients who have PCOS, weight loss. I mean, and I think Sokola said it, Dr. Sokola, weight loss can just do wonders. I've had patients who lose 5 to 10 kilos and come back and tell me, Doc, I'm pregnant. And yeah, because you regulated your hormones somehow and we got pregnant. So just lifestyle change does a major, major factor. I'm not telling you to do lifestyle change without having a diagnosis first. I think the first step is you need to understand what's your diagnosis, what is it? Because you can be chasing that and then you have a male factor as well, or your husband has a sperm problem. You're not going to get pregnant. So the first thing, of course, is get a diagnosis, get checked. And I know it's scary, very scary, because you've been together maybe for 2 years, 3 years. Nobody wants the blame game, but it is really, really important to know what the problem is. And earlier on in your relationship, I think, not after 10 years of trying. So I've really liked that when I started, we would see patients who are 45, 43, but now I'm seeing patients who are 28, and it's such a breath of fresh air, because I get happy. I really get happy because there is hope. I can do so. You have so much time. There's so much hope, even if in women who have very few follicles at 28, because there are women who have premature ovarian failure. Their eggs age a little faster. But even with those women, they have so much hope because of their age. Age is the biggest and most important factor of fertility for a female. So if there's nothing you hear today, please, that's what I'm preaching. Please get tested early. and know exactly what you want. I don't know if you saw the Jennifer Aniston issue, and I'm liking that celebrities are going out there and saying it more and more. She says if she knew, she would have frozen her eggs earlier. And that's actually what I'm preaching this year, because I'm seeing that more and more, that people don't know. Someone comes at 46 and tells me I want to conceive, and I'm like, it's really not possible at that age with your own eggs. And then they say, oh, but I saw other celebrities at 50, at 52 getting pregnant. I mean, if you can't do it here, then I'll go to the US. And I'm like, they either froze their eggs or they did something or used a donor's egg. It's not genetically theirs. So this is very important. And we have all these stories on media. 54-year-old gets triplets. It's not theirs, or they froze. So this is one thing to understand. So anyway, so there's weight loss. That's very simple. If you have endocrine issues that you can take medication if you have hyperprolactinemia. There are medicines to reduce the hormones. If you have thyroid issues, there are hormone treatment to set that right. So those are very simple steps that can be done. Then there are modalities that are a little bit more involving, and there's something called ovulation induction. So this is for patients who are not able to ovulate on their own, or have haphazard ovulation cycles. And all we would do is give them some medication, follow them up with scans, check, are you ovulating, when are you ovulating, and then we would ask them to have intercourse at the time of ovulation. You can do ovulation sticks as well, you can time. So there are many other ways to just check when are you ovulating and then time it appropriately. But as I was saying, if you're having intercourse 3 to 4 times a day, 3 to 4 times a week, and living with somebody for 1 year, and you're ovulating, then there's something else. It's not the ovulation. You must have gotten it right at some point. And remember, as women, we are hormonal. When our libido goes higher, it's likely that we're ovulating when we have a higher libido. So usually your body conforms to what it wants, to be honest. But if not, then we can help you ovulate. There are other things like an intrauterine insemination, which is also called artificial insemination, where we are able, especially in cases where the male sperm has an issue, either it's a little bit slow or the numbers are a little bit lower than 40, maybe they're 20. So natural conception will not work very well. Then we're able to concentrate them and put them into the uterine cavity at the time when you're ovulating. So that requires, again, some medication on the woman's part, some scans to check that the egg is growing. To time the ovulation, we give you an injection, and then we do the intrauterine insemination at the peak time of ovulation, which is just, we put a cannula, a little catheter into the cervix, and then put the sperm in. And the sperm has been processed, it has been washed. It is not sperm that you took to somebody's office and they just put it in. There are techniques that are done in the lab to ensure that it is a bit faster and actually works. And then there's the big IVF, which everybody's scared of, but sometimes, unfortunately, it is the only thing that will help. IVF is a lot complex. I don't know if you want me to get into it at this point or at some other point, but IVF is a little bit more complex, but it does have the highest success rate, but also has failure rates. And therefore, before you go into an IVF cycle, you need to have understood what it is about, the emotions around it, because it can, I've seen, people just literally say, I don't want to go through, it was too much. So it's very important to get proper counseling before going into any treatment anyway as well.
Okay, and maybe just touch on Vincent's question for, if tubes are closed, how will they open? And does it guarantee conception and other factors remaining constant?
Okay, yeah. So tubal blockage is one of the most common problems we're having in Africa. And even around the world. I like that how we say Africa, but it's also in other countries. Unfortunately for tubes, there is a very low success rate of tuboplasty. And tuboplasty is where we try to open up the tubes and have flow. And the reason I say that there's a low rate, and it's because also to caution patients. Tuboplasty means that we would have to cut the section of the tube where it is blocked. So we are assuming it's a small section, but it could be a very large section of the tube. The tube is about, I don't know if you can see this, but it's about the size of a biro or a bit less. So you can imagine if the inside of the tube is as small as probably this point of a biro, and I have to open it up, stitch finely to put back the tube together. And if you've ever had a wound that is this big, you know that when it heals, it shrinks with fibrotic tissue. So you can imagine trying to stitch together a very small area and having it not heal back with fibrotic tissue. It's really very rare. If you really have tubal blockage, it's not very common. It's about 7% of cases that will actually be successful to be opened and then have a conception. The other thing about tubes is if it is an STI, STD, sometimes it has also affected the cilia. Inside the tube, there's what we call cilia. Cilia are little hairs, just like I think we have, they're little hairs inside the tube or little structures that allow the movement of the ova. The ova or the egg has no way to move. The sperm has a tail and it's able to move through the tube, but the ova has to be pushed by the little hair, the little cilia, microscopic things that help the tube move. Now, once you have an infection, there's also a likelihood that the cilia have been destroyed. So you could actually have an open tube. I could have opened it, or we could have opened it surgically. But if there's no cilia to propel the ova to the sperm, and then after fertilization, remember, you form an embryo. The embryo also has to be moved or pushed towards the uterine cavity. So if there's no function, then we're also not going to be pregnant. So the tube is it's one of those organs that's very important, and its function is so key. So if some people have a tuboplasty that's successful, especially if it's at the edge of the tube where the opening is the widest, that may work. Or sometimes it wasn't really blocked. The HSG, I like to look at it, sometimes is not, maybe somebody didn't push hard enough. So HSG can also be misleading at some point. Or if the tubes are blocked at the beginning, sometimes there's something we call a spasm. Like your tubes will spasm, the muscles will spasm and not allow the dye to go in, yet they're actually open. So those type of instances, they weren't blocked. And when we go for laparoscopy, we push there and we find, okay, these tubes were not blocked. So I think tubal blockage also, you have to analyze it with all factors also, because, and why I want to speak about this is, if you come to me at 42 and your tubes are blocked and you ask me, doc, I want a tuboplasty, I will actually say it's not the best for you because you have 1 year to conceive. I will go in, try that tuboplasty. We give you 6 months. You're 42 and a half. Then now we start doing things. We've wasted actually 6 months. So I think tuboplasty or opening tubes has to be also in connection to everything. And once, before you go in for a tuboplasty, and this is just for everybody, all factors have to be checked, because you might go in for a tuboplasty and then there's sperm factors, or there are fibroids, or there are other things that haven't been checked. It's very important for your whole examination to be done before you go in for any surgical case or any treatment option.
Okay. So Kwala, do we have hope out there? What does the endocrinologist do?
So, like I said, like most of these conditions related to endocrine conditions are luckily treatable. So if you've got high prolactin levels, for example, from the brain, then you can actually, give medication to suppress. In fact, even if you've got tumors that are producing high prolactin, if you just give some medicines, they can actually suppress the tumors. And we have achieved pregnancy rates just by giving those medications with high prolactin levels. When you've got PCOS, then again, one of the best options is weight loss. And weight loss here, we are looking at options related not only to lifestyle modification. Of course, at every stage for weight loss, you do need lifestyle modification where you've got a lower calorie, lower carbohydrate, preferably diet. with association, in collaboration with, physical activity, like we mentioned, moderate intensity physical activity, at least about 30 minutes in a day for 5 days in a week. And in addition to that, you could plus minus use some medication for weight loss. And nowadays, there are studies also looking at the effect of surgery. There are surgical options also for weight loss, for those who cannot achieve weight loss using these other modalities of non-surgical therapeutic options. So weight loss with fertility treatment is very key, or having a good normal BMI or normal weight related to your height. And that should be a goal to look at preconception, even as you're planning pregnancy, to achieve good weight loss. And that's not only to help with fertility, but also with pregnancy outcomes, because if you're conceiving when you have excessive weight, that already puts you at risk of even high blood pressure and diabetes in pregnancy, and poorer outcomes of the baby. So generally, weight loss is something that we would recommend to anyone who's planning to get pregnant, and that can achieve marvelous results in especially patients who've got underlying conditions like polycystic ovary syndrome. So I can just not overemphasize on the aspect of lifestyle modification for achieving fertility benefits. Then conditions like thyroid, she's already said, Dr. that those are treatable. It's not, once you identify them, then there is treatment for most of these other conditions. Of course, there are certain conditions where treatments may become difficult, like if you've got a congenital problem where your body cannot produce, certain hormones at all, then you can have challenges. But even with that, nowadays, we've got treatment options that are available. However, certain conditions, like if you've got primary testicular failure or you've got premature ovarian insufficiency, that is one condition that viewers need to be aware of, is that before the age of 40, when you're supposed to start thinking about possibility of perimenopause and even menopause later after 45, if you do get, your periods just become extremely regular, highly spaced out, they start reducing in amount, you start getting hot flashes, then those are the patients who should start considering whether they've developed primary ovarian insufficiency, which used to be called as primary ovarian failure, because that condition also is something to look at. So if it is identified early that patients are going towards it, then we could, at that point, if they are looking at fertility as an option, do consider retrieval of eggs. And that's the point where you would probably want to assess whether there's any eggs available and consider fertility treatments at that point. However, that's a bit of a difficult condition to treat once it sets in. That's primary ovarian insufficiency. Again, if another advice I'd like to give is what Dr. was talking about with ovarian, like follicular retrieval or banking, is if you are, like, there's some cases where patients have, let's say, cancers, or they require radiotherapy to the area, in an area which is related close by to the genital or to the ovarian areas, then that's the patients who should consider follicular or retrieval of eggs before they get the procedure done, because that could actually affect your oocyte production and could lead to premature infertility or ovarian failure as well. Again, with some chemotherapy agents, remember that before you start going for that, you need to get your eggs retrieved, so that later on, if you're planning pregnancy, you have a better option than compared to if you didn't get your eggs retrieved at your earlier age or before you went for chemotherapy. Because remember, if you've got your eggs retrieved and you have an intact uterus, then you do have a higher chance of conceiving even naturally or also through artificial or assisted methods of reproduction. So those are the things to consider. Then there are hormones nowadays available which help you with the, other than ovulation induction, also which the hormones which are produced normally by your hypothalamus and pituitary. We've got recombinant forms which are available for that. I was reading something very important, very interesting, maybe Dr. Wanjiru can talk about, for patients with, uterine problems. If you've got a problem with your uterus, they've tried in certain cases for uterine transplants. I don't know how practical that is. They've had some successful pregnancy cases, but of course, that's a far-fetched thing, very expensive, not available in our country, but there was an interesting read, I think. I think hormonal issues are easy to detect. There are tests available. if they are picked, they are easier to treat, and they can, if you've treated them, then there are higher chances of achieving fertility in these women.
Okay, as you answer, Wanjiru, as you answer Sokwala's question, would you touch on surrogacy, especially in our setup in Kenya?
Okay, so yeah, thanks, Dr. Sokwala. When the first uterine transplant was done, everybody was so happy. The only issue is, one, it's a very difficult surgery. Sometimes it doesn't, the transplant does not succeed. And nobody has done it here. I don't know if it will be because here we do surrogacy. I know the first one was done, in countries where surrogacy is banned and is not allowed. In our country, to be honest, surrogacy is a gray area. There are no laws. We have no reproductive laws, assisted reproductive laws in our country. So we are still in a very gray area. But surrogacy does happen in our countries. The only thing is that it has to be, there are laws, silent laws that we use just to ensure that we're on the right side, because we do have something sitting on in Parliament that has not been put into law yet. But I do think it's a gift, to be honest. I am very pro surrogacy, because if I have eggs, and I have had many surrogates, and the reason is, a woman who has had fibroid surgery went back, bled, they had to remove her uterus, they left her ovaries. Does she have a right to have another child? Of course. People who have had something called Asherman syndrome. Asherman syndrome is where there is a lot of scar tissue in the uterus, and we are not able to achieve an implantation. So some of these women they have viable eggs, but the uterus is not able to function. Those are patients for surrogacy. So for us, we only take patients who actually have a reason to have a surrogate. Medically, they will not would not be able to carry a child. We've had patients who've had multiple repeated miscarriages, and we've done everything. You've done everything that you could to stop a miscarriage, but it doesn't. So those patients, we also do surrogacy for them. And I think that surrogacy, it's just gray. So we have to have contracts in place. There's a lawyer we use who has contracts, because the lady who is doing the surrogate has to be well informed. She has to be given something for the time and off work that she's had. But I think it's a wonderful gift, and it is available, but it is very strict in terms of who we allow, because I have even good friends who just want to have a surrogate because they don't want to carry the pregnancy. That's not allowable here, but remember, yeah.
Okay. Let's, Hamida, of course, because I want to wake you up again. So when do we tell a couple tumefika mwisho? I know my friend Joanne doesn't like Swahili, but there's no better word than tumefika mwisho. Tukubali and either stay child-free or adopt. When do we start that conversation?
I think, of course, it's based on the feedback that they're getting from the doctors. I'm not in a position to make that decision for them. But once they come with that kind of news, then we have to go. Because remember, there's a sense of loss throughout this process. So we are going through the grief processes. And we are basically, when that information comes back that now, wamefika mwisho, then we are going through the grieving process. I'm supporting them. And each couple is different. And even if we're talking about a couple, we're talking about the individuals. Maybe the woman is moving faster in their grief than the husband. So we move according to the pace of each one of them until they reach a place where there's some level of acceptance. And there may be acceptance or not. It is not guaranteed. Some of them might be okay with exploring other options like adoption or surrogacy, but others may not. So each person, each couple is completely different. Yeah.
101, do you tell the couple mumefika mwisho?
I think that's a very hard question. I really feel, well, I think it's mwisho of what? Because I mean, there are, as I've said, there are donor cycle aspects. It may not be your own genetic child, but you can carry a child who doesn't have your genes but has your spouse's genes, and therefore society will never know that it's not your child and stuff like that. So it's a very personal aspect. But of course, if we've done 1 or 2 IVF cycles and the egg quality, the embryo quality is just so poor, or sometimes they don't even reach out of the incubation phase, then I mean, that's a couple who need to understand this is not going to work with your gametes together. You may think to do it with either a donor cycle, or you may decide to adopt. Sometimes it's both the husband and the wife who have a problem. So is adoption better than getting, you know, I think it's very complicated, but it is, I think I try and explain, this is your chance. You decide whether this is really, are you going to go through the financial aspects? Are you going to go through the emotional aspect of another failed cycle of IVF? Or are you going to just decide to either do a donor cycle, or is that not for you? Because there are patients who will say that's not for me, or that's not allowed in my faith, and therefore then do you then decide to adopt, and that's still okay. So I mean, a family is not genes and genetics, really. It's really about the bond you have between you. And I think one of my patients once, they told me, you know, he didn't grow up with his father, and unfortunately he was going for a donor cycle because he had no sperm. And he told me the one thing, he doesn't know his biological father, and therefore it didn't really matter, but he had a father who took him through and who he calls his father. So unfortunately, if he has been deemed the same fate, that he won't have the genetics of his child, but he will have a child with his wife, that's all that's all that was okay for him. But again, it's very individual. It's not, people have different faiths, people have different beliefs. So yeah.
Okay. So Kwala, do you want to add on to that?
Yeah, actually, I do happen to belong to one of the faiths that do not allow for donor eggs, right? And so in certain individual cases, you come to a kind of dead end earlier than others. And it's also dependent on how much they're willing to, what mile they're willing to go. So I've got relatives, leave alone only patients coming to me who have even got treatable causes of infertility or subfertility, and who opt, no, we have reached, this is where we have reached, and we don't want to go further than this. So that's where now you'll call it off, because that's the individual choice, and they decide, no, we would rather go for adoption rather than going further and assess and you know, going deeper into it and doing more tests and all that. There are some patients or some people who are willing to go beyond, even when they've got, you know, primary testicular failure, they've got ovarian insufficiency, they're still willing to go the extra mile, go for possibility of surrogacy, for donor egg, and, you know, reach to the maximum that they can with ICSI, with the assisted reproductive techniques. So those are the patients you'd walk the mile with them. But what I feel is there's a very important role of the counselor when it comes to this kind of cases, which you need to be involving early on in the management. In fact, what I believe is by the moment couples are coming for infertility assessment, after we have evaluated the most common causes, and as they are moving into their journey, and you realize that their chances of conception, and obviously by the time they are coming for infertility management, already that means that they've had lower chances than the general population for conception. And as you are trying to treat the causes that are treatable, you still have to be counseling even at your own level to make them understand that, you know, be preparing for possibility of failure at some point, and understanding to what mile they're going to be going, so that if the causes surely, you know, are going to be treatable, like if they've got Graves' disease or thyroid problems, and I can remove the thyroid and probably achieve fertility after that, then fine, well and good, you prepared them accordingly. But cases like now you're saying issues related to conditions related to, potentially, more difficult chances of conception, like Dr. Vanjiro has already talked about, they've had 1-2 cycles of IVF, then you need to start counseling them early on that this is the situation and we might not be able to totally conceive in that case naturally, and see where the patient belongs. So I would totally echo what she had said as far as individualization is concerned. So I think fertility and subfertility, infertility is actually a journey, and we have to be there holding the patient's hands as a team, where the counselor is involved, the endocrinologist, if it's an endocrine issue, and the gynecologist is involved, and we are dealing with the patient together as a team to be able to support their care. Thank you.
Thank you. So can you hear me? My screen is frozen. Can we look at the myths that surround infertility and just demystify them? Wanjiro, are you able to take a stab at that?
Yeah, well, I think there are so many myths. I think every cause of fertility has a myth. Every treatment option has a myth. So I think for me, the biggest myth I would say is that that I hear is one, that it's a female problem. But now, as I've said, I'm really loving that couples are coming together. But unfortunately, in our African society, it's still the woman, despite everything. So you find women, I think, bear a lot of the burden of fertility, even when it is not them who have the problem. And they can even be silent about it because they don't want to shame their partner. So I think that fertility is only a female problem is the biggest myth, and I think it's still perpetuated a lot. And it should be quashed. I think the other myth is that that IVF babies are abnormal. I've had a lot of that and a lot of questions around that. If I do have an IVF cycle, that baby will not be really normal. There'll be something wrong because of the chemicals in the lab, and that's a myth that is not not true at all. I think the other myth, of course, that a lot of people subscribe to is that if I have a menstrual cycle, then I'm still fertile. And I think this is the biggest one of the biggest thing that women need to understand, that having a menstrual cycle does not equal to quality of oocytes. So I'll have a 48, 40, 50-year-old coming and saying, you know how I have a regular cycle, I have a 28, it doesn't even miss one day, it comes on the dot, or my calendar, my app, it's spot on, and therefore I have to be fertile. And unfortunately, that is not true. And the reason that is not true is that women, 10 years before we enter into menopause, the egg quality just collapses. So if you're going to have menopause at 53, by 43, which is the more, your eggs are poor quality already. And that's something I try really to educate people, because a normal regular menstrual cycle is not equal to the ability to have a natural conception. Another thing that people say is that the fallopian tubes are not blocked because I have a menstrual cycle. So that's a very common thing, that how can my tubes be blocked and yet I have a menstrual cycle? I think people don't understand that the menstrual cycle or the blood comes from the endometrial cavity and actually has nothing to do with the tubes. The tubes are just an organ of passage for the gametes, but the hormones surrounding the FSH and the hormones that allow the ovary to actually ovulate, and after that, if conception doesn't occur, prepare the lining of the womb. And if the womb is not inhabited by a conception, then it will shed. So it has nothing to do with the tubes. So I think those are really my three. Oh, and the fourth thing about surrogacy, some people ask, but that baby doesn't, then the genes are for somebody else, and that is wrong, because the womb is just a carrier. So it has nothing to do with the genetics of the baby if somebody else is carrying for you.
Okay. And the myths that surround men, underwear, hot showers. Yeah.
To some level they are correct. They're not really myths, because I mean, for like, if you are a long distance truck driver and you sit on that hot engine for 8 hours, 10 hours of the day, most of them, or some of them have low motility of sperm. So sperm are affected by temperatures. It is not also uncommon that we have a higher male infertility aspect in the hotter regions of this country. And that is because of the heat, and also because of some conditions like varicocele that happen with that heat in those regions. So heat for a man is actually not recommended, but it's the durations and it's the frequency. So if I have a hot bath once a week or once in a month, I mean, or if I go to the sauna, because that's what's coming up, once a week, that's not gonna affect you. I mean, but it's if I'm in the sauna every day, if I'm putting hot things there every day, of course it's gonna affect later on.
Okay, and could you also touch on, the miras, the shisha, the bang, alcohol, and infertility?
Yeah, so all these things are toxins. So our body is very sensitive to toxic substances. And what it does, toxic substances somehow have a way to go to the cells that replicate faster. And sperm replicates, skin replicates. People who smoke have terrible skin and stuff like that. But in this aspect of the sperm, it does really affect, but sometimes it's only the motility or the numbers that are affected, and and sometimes the way they look. But the beauty is, for men who stop it, and maybe sometimes we put on antioxidants, but these are men who have borderline levels. So maybe your levels the normal level is 40 million, and maybe you have maybe 35, 30 on your semen parameters. And you are alcohol, smoking, mira, or do all those things, once you stop, and after 3 months when we assess you, sometimes the levels have gone back to normal. So this is something that I really stress for men, that they do actually affect the sperm parameters, but again, not for everybody, because I also have patients who are heavy smokers, heavy everything, and when we do a semen analysis, the sperm are perfect. But for a large majority, it is a factor.
Okay, and can we eat our chia seeds into fertility and all those Chinese herbal products? Are you able to just comment on that, the effect or ineffectiveness of them, or the toxicity of them? Because I know there was a huge deal about the pill that people were taking once a month, and the way it was affecting babies who were born of those mothers who got pregnant. Different issues, but yeah, just in general.
I think what we're really trying to say is, one, live a healthy lifestyle and just watch what you ingest, because at the end of the day, toxins have a play on each and every cells, every cell in your body. I'll just talk about the chia, because I'm telling you, chia, maca powder, I don't know, people are on everything. Someone brings a whole pharmacy of medication. I'm not saying it's wrong, but excessive use of this medication, whether they're supplements, are also harmful. Vitamin D in excess is extremely harmful. Vitamin A. So I really feel that our marketing has pushed people to think that all these things are extremely beneficial when they're actually not. I won't touch on one of the herbals that are out there, but it's really affecting people, because people say, oh, but my friend got pregnant when she took it for 3 months. But what is your friend's problem? If she has fibroids the size of a pregnancy, which I've seen, and is taking those herbal things that say they will shrink their fibroids, I mean, come on, it's not going to happen. Maybe your friend didn't have fibroids, had maybe a hormonal issue, and all she did is those things plus exercise, plus she changed her diet. So is it really those things, or is it because she exercised and changed her diet? So I really feel there's first of all, we don't know what those things are. There's no and that is the problem, that when I give medication, I actually know it has this amount of this amount of this. It has been regulated, it has been tested on patients. There are trials that have said that it does improve your fertility. But if you're taking some concoction that you don't even know what is in it, I mean, for me, that's just not right.
Okay, so Kuala, you're up. On your side, any myths you want to bust?
Sorry, I didn't hear that one.
Dr. Sokwala. Yeah.
I think Dr. Wanjiru has covered them all. I think the biggest challenge we face even within the communities, like the Asian community especially, which we see the whole aspect of blaming the female, that fertility is a female factor thing. That has to be bust very heavily, I think, because a lot of societies believe that, not only with fertility, but also conditions like PCOS. Again, that's something that is really looked down upon, frowned upon. So those are things that people need to be educated about, that these are conditions which are treatable, which have an underlying problem, and should be looked at as such, and that there's treatment available. And that's where you find a lot of shunning of. So there's a lot of, other than myths, is stigma aspect related to it in our societies. So patients with PCOS, for example, they'll have excessive hair growth on their faces, which is what is known as hirsutism. They'll be having hair losses, and those are considered to be, there's a lot of spirituality associated with this kind of conditions, and such women are really looked down upon. They'll gain weight, and this is not of their own liking. And that's supposed to be understood, that these are real conditions which are existing and which have treatments available. That's one of the issues we face a lot, such that those girls are not even to begin with, considered for relations, for marriages. And then when there's this whole issue of infertility that comes in later. So they're just considered, shunned off. And you see a lot of psychological and social and intermarriage issues that come up, and that leads to a lot of issues, just not related to fertility, but overall health of these women. So we need to accept them and look at the possible treatment options in these cases and seek for them actively.
Okay, Hamida, what unhelpful things are people saying out there? And I don't know if Sai is back, because he's usually our pastor in this conversation, but what unhelpful things should people stop saying? And while you're at it, I think we are going to wind up, because it's 2 hours in. And if you have questions, just put them in the chat or raise your hand. If I see it, you shall ask, and then we can wind up. But Hamida, go.
For me, I think I would want to just talk about people's identity, tying your identity to your fertility, because some people are not able to move past that. It's like, if you're not able to have a baby, or you're not able to have a child, then you're lesser than. It's just important for us to understand that somebody can actually have a full life without a child. Another thing that is very important is to realize that it is not a guarantee that once you've had children, then you are going to be happy for the rest of your life. I do a lot of parenting workshops, and there's a lot of parenting also comes with a lot of its own challenges, and it's not every parent who gets to enjoy being a parent. Yeah.
Okay. Njoki's iPhone, go ahead.
Thank you. Thank you so much for this opportunity. And I tell you what, these are so informative. I thank you all for the information. Here's my question. My question is essentially tied to sex and sexuality. I'd like to find out how this whole process of, fertility and suboptimal fertility, and the seemingly mechanical processes of a couple trying to get these children, how has that affected sex and sexuality? And also, how have this changing interactions that different demographics have with sexual content influenced fertility or infertility, if at all? Thank you.
Okay, that's anyone can take a stab, or I will choose.
I think it's a loaded question, but maybe I can just answer it from the psychological aspect of it. With the clients that I get to see is that, you know, sex and the pleasure of having sex is put on the back burner, and you find that many couples will just look at sex as, you know, a way of conceiving. So you may find that couples are actually not enjoying each other when it comes to their intimacy, and that of course has an impact on their relationship. Yeah.
Okay, Wanjiro, because you're seeing these couples, are they feeling like they are just it's like the cow in the farm just being tacky bastard or something like that? What are they saying?
Now, I think it's very obvious that any couple who are struggling with infertility will have issues in the bedroom. But I just want to say that sometimes it's actually started before. And therefore, I sometimes, and that's why let me just say that I caution them a lot, especially patients who come and they say, we've been together for 3 months, we have not conceived. And I'm like, 3 months is such a short time, especially on the basis of age. Sometimes you're 28, you're 27, and because when you start timing that I want to have sex on day 14, it just becomes mechanical. And I have been called at 3 a.m. in the morning at one point, and I actually wondered how do I help you that someone is not performing? And it just brought a lot of grief and a lot of stress, and it can bring a lot of turmoil. And therefore, I do caution that sometimes it is very essential for patients who are struggling with this to also talk about other things and other dynamics in their relationship. A lot of patients don't like to see counselors or psychologists, and that's what I've seen. It's really difficult for a lot of patients to see counselors until they've had a failed cycle, and that's maybe sometimes when they agree. But I do want to say it does affect, and sometimes it's just counseling that will help, and also to know that this is a normal occurrence with other couples as well. But I also want to say that the changing dynamics, and I think this is what Joki wanted a little bit of insight. Dynamics are changing. There's a lot of pornography on screen and on your phone, and therefore we are not having to go to hidden places. We can sit in our bedroom or whatever and watch pornography. And for me, this is very it's a terrible thing, because what it's doing, and this is, we are seeing more and more, it's raising expectations for men. Pornography is very unreal. And yet I have people coming in and saying, I mean, my size is not okay. And you're like, what do you mean? Whose size did you see? You see, and those are the problems, that you're watching those. And then also, I think the sexual pleasure, or what it does to your mind, is a little bit more elevated or something for some people. So you're actually, I'm struggling with sometimes patients who are not able to have actual intercourse with your wife or your partner because it doesn't satisfy you. And I think this is the biggest problem of all these sexual aspects, because it's causing infertility that shouldn't be, an infertility problem. And this is why sometimes for my history, I'm starting to ask, how many times of a week do you have intercourse? And sometimes you're finding that people don't have intercourse. Newly married couples are not having intercourse for 3 months. And I'm like, really, this is why we're not conceiving. There's no other problem. And when you go back to it, it's because I'm not able to sexually satisfy her. I'm not able to have an erection with her, but he's able to give us a sample when we need a semen analysis. So I really think that, I don't know what will be done. I guess it's just prayer and to guard our young men that off of these things, these habits and these things that are actually detrimental to even their life as a couple later on. And then it affects the woman, to be honest, because she finds, oh no, he's not satisfying me. He's not able because he doesn't love me, or, so it's really, it's very twisted. Huh?
Okay. I think we can close because Kenyans must eat dinner, right? So Kwala, do you have you can you can close with your closing remarks, and then Hamida and Wanjiro can also do their closing remarks. Then we go eat brunch and eat dinner.
Yes, thank you. Thank you for this session. I think it's highly educative, even for me, learning from colleagues as well. And this whole aspect that you've created of the team discussions, I think that really matters a lot to deliver the message accurately to our listeners and our viewers. What I'd like to say is, sexuality is a whole field that has changed significantly over the past several years with exposure to different access of younger and younger people. And not only that, it's also the whole aspect of the stresses of life that have increased. Sedentary lifestyles have increased. Lifestyles overall have changed over the past. The access to, the whole, prevalence and incidence of depression, of psychological or psychosocial aspect is also grown significantly. And all these aspects come into play, not only the medical or the pathological aspects that we have talked about when we are looking at the whole aspect of fertility and infertility. So treating individuals for infertility is a journey, like we've already said, and it should be done in a very structured manner with a lot of patience and a lot of commitment and involvement of the team. I think my take home is that it's not a one-person job. It has to be a team-based approach. And the counselor should be key in this whole journey that we walk through right from the beginning. Thank you.
Okay. Hamida, do you want to, what's your take-home message?
Yeah, I think just what Dr. Sokwala has said, that, as much as there's the physical aspect of the treatment when it comes to subfertility and fertility issues, your mental well-being is quite detrimental. If you don't work on that aspect of yourself, then the journey can be quite tiring. And just to mention that, this year, one of the things that I'm putting together is having group therapy for people going through, issues of fertility. So just small groups that we are going to be working together in very safe and confidential spaces and support each other. Yeah, thank you.
Thank you. And if you're here and you belong to a support group, you can put the link for your link to your group in the chat. Wanjiro, your take-home message?
I just think I think everyone has said, and this has been a very insightful discussion. And I think the only take home is that it is a journey, and I think you need to come to the journey whole first before going into it. And I just applaud anybody who is walking in those feet. And I just want to tell you that there is hope. So don't give up. There is a lot of hope out there, but it starts by you seeing somebody who can actually help. We don't make babies, and that's the thing. We are not God. We don't make babies. I really do believe that they come in His time, if it is in His plan for you. But there is hope.
Okay. Sir, are you back, or I'm the one who has to do English of the nose? Okay, Sir is the one who
do English of the nose.
Yeah. I have to do English of the nose. Okay. Thank you so much, Hamida, Dr. Sokwala, and Dr. Wanjiro. Thank you. This was beautiful. This was wonderful. And join us in 2 weeks we are going to discuss chronic pain. So all our sickle cell people, fibro people, people with cancer pain, you can join us. And kwaherini, asanteni. If you'd like, subscribe, follow us on Facebook, follow us on YouTube. And if you have a topic of interest and panelists who can freestyle like the way these three have done so beautifully, they can reach out to us on through our page on Facebook. Asanteni na kwaherini. Bye-bye.
Goodbye. Thank you very much.
Bye. I'll give you 2 minutes to talk. Bye.